Good evening, everyone, and welcome to our webinar, Unlocking CAR-T, a special edition patient education webinar. Tonight's session is a break from our typical Lupus and You series, as we focus on a groundbreaking topic that's been making headlines across social media and major news outlets, CAR-T cell therapy. My name is Jaron Crone. I am in the research department at the Lupus Foundation of America, and we're thrilled to have with us a stellar panel of experts, including Dr. Anca Askanase, Dr. Elena Massarotti, Dr. Richard Furie, as well as our special guests, Christopher Cedeno and Talaya Reid, who will be sharing their personal experiences with CAR T cell therapy. Before we begin, we would also like to extend our sincere thanks to our sponsors, AstraZeneca, Bristol Myers Squibb, Cabaletta Bio, Kyverna, and Novartis. Your generous support enables us to host programs like these. Just a quick note before we get started. At the bottom of your screen, you'll see a Q&A feature. Please submit any questions you have there, and we'll do our best to answer them throughout the evening or during our panel discussion at the end. So without further delay, I'm honored to introduce our first speaker, Dr. Richard Furie, Chief of Rheumatology at Northwell Health. Dr. Furie will start us off by discussing the role of B cells and their significance in lupus. Dr. Furie, you can take it away.
All right, thanks so much. Here are some disclosures. All right, so this evening is all about B cells and how we can get rid of them. Next slide. But I want to provide some background. I want to provide the foundation for the other speakers' talks. So some of this may seem a little too technical, but you can ask us questions at the end. Your immune system is very complicated, and it's divided into the innate immune system and the adaptive immune system. And the innate immune system is evolutionarily very ancient, not only found in all animal life, but actually in all plant life as well. The responses are nonspecific, and nothing is sustained. But examples of items in our body that are part of the innate immune system include the complement system, neutrophils, which gobble up bacteria, something called toll-like receptors. Now, if you go to the right-hand side of the slide, you see characteristics of the more sophisticated adaptive immune system. And this is evolutionarily advanced. It's found in vertebrates only. And the responses are very specific, what we call antigen specific. And then there's memory to mount stronger and stronger attacks. And examples would be B cells, which is pretty much the topic tonight, antibodies, and other types of white blood cells called T lymphocytes. But there's crosstalk between the two. Next slide. Now, here are some of the white blood cells. Some of them look happy, some of them not so happy. But if you look in the second row and 3 over, you have the B cell. And those little things, the little Y-shaped structures coming out of the B cell represent antibodies. And more on that in just a bit. Next slide. So here are what are called lymphocytes. We all have lymphocytes in our body. We have other types of white cells as well. We have neutrophils, which, as I mentioned, gobble up bacteria. But lymphocytes do a bunch of different things. And you can see I have the B cell circled. And you can again see those white Y-shaped structures coming out. Those are the antibodies. And they make protective antibodies. But in the case of lupus, they also make the autoantibodies, the DNA antibodies. And the B cell gets some help from the cell all the way to the right, the CD4 T cell. And then you have other types of T cells, regulatory T cells and CD8 T cells. So again, a very complicated system, but we'll focus on B cells. Next. So this gets even more intricate. You can see a B cell in the center in this cartoon. And there are a lot of different proteins on the B cell. So if we want to try to get rid of B cells, we can try to target some of those proteins. And that's what we've done over the last 25 years. And I'm not going to go through all the different targets. So one you might know, which is on the far right, you see something called BLyS, B lymphocyte stimulator. And that's the target for Benlysta. We're going to talk a little bit about one at 12 o'clock, the CD20 protein. That's the target for Rituxan. But there are a lot of other targets, and you'll hear more about this a little bit later. Let's go to the next slide. Just trying to simplify things a little bit. Now we can click through this, yet other targets. And it's been an amazing 25 years. We've targeted so many different parts of the immune system in lupus, and we wish we had more drugs approved, but we have 3 drugs for 4 indications. So one of the drugs that made a historic entree into the lupus field is belimumab, or as you know it, Benlysta. And this is a monoclonal antibody. So this is a recombinant antibody, sort of synthetically made, that targets B lymphocyte stimulator, also known as BAFF. And the reason for targeting BLyS is that it is a key growth factor for B cells. So if there's no BLyS in the body, B cells will not grow. Is that good for lupus? Well, it is, because it's the B cell that's overactive and making all of those different autoantibodies in lupus. So if we can subdue the B cell by sort of starving it of BLyS, that's a strategy to treat lupus. Next slide. So Benlysta got an approval in 2011 for systemic lupus, and then more recently, a few years ago, for lupus nephritis. And I'm just showing you an example of the data that led to the approval. And this also was a historic event because Benlysta was the first drug to be approved, to be formally approved by the FDA for lupus nephritis. And it's a complicated table, but the metrics that led to the approval are listed in the far left. And if you look at what I have highlighted down the sort of the center in red, that's what's called the treatment difference, or we'll refer to it as the effect size. And in all of these studies that we do, we compare the active drug to a placebo being an inactive substance. Now, background therapy is typically allowed. So it's not just the one comparison of placebo to the drug. And then we just look at the difference in the rates of the achievement of those metrics that are listed on the left. And the primary endpoint for this particular study was something called PER. Sounds like a cat, but it's the primary endpoint of renal response. Anyway, so you see superiority of the group that got belimumab compared to placebo, again on background therapy. So this is just an example of how one displays trial results. Next slide. So if Benlysta starves the B cell of a key growth factor and seems to improve lupus, right? We had 2 approvals, one for SLE, one for lupus nephritis. What if we just eliminated the B cell? And Rituxan, or rituximab, is an antibody to CD20, and I showed you that on the cartoon. That was that protein that was up around 12 o'clock on the B cell. And Rituxan does just that. It depletes, it eliminates, it kills B cells. So if you go back, gosh, almost 20, 25 years ago, we designed 2 trials with Rituxan. They were called the Explorer trial and the Lunar trial. Explorer was for systemic lupus and Lunar was for lupus nephritis. And we thought it was a shoo-in, just do the studies, kill the B cells, and we'll have 2 new drugs approved for lupus. Well, as you can see in this slide, both studies failed, to the absolute shock of the lupus community. So why did they fail? And this is important because this is the basis for what you're going to hear in a little bit. The next slide. Well, we did the study because we knew Rituxan would kill B cells. After all, it was approved for certain kinds of B cell cancers, for lymphoma. So it would seem to work in lupus. And here you see these 2 curves. And as I mentioned, there's a placebo group and then a treatment arm. And the B cell numbers are on the y-axis and time on the x-axis. And you can see the group that got Rituxan depleted their B cells, and the group that got placebo did not deplete their B cells. Yet, the group that depleted their B cells did not have a superior clinical response. Next slide. So why did those two studies fail? Well, here are some hints. Work done in England, up in Leeds, both in rheumatoid arthritis and in systemic lupus, came to the conclusion that if you don't completely deplete the B cells in the body, then you're not going to get an optimal clinical response. So the conclusion was more is better. More depletion may be better. And then there was a small study looking at patients who had received rituximab for certain reasons, who were undergoing kidney transplant. And the investigators were able to harvest lymph nodes around the kidney. And what they found is, if you look at the peripheral blood, the regular blood, the B cells were depleted, but they were not depleted in the tissues of the lymph nodes. So it told us that maybe Rituxan was not powerful enough to deplete the tissue B cells. And then there was yet another study listed on the bottom doing a post hoc analysis of the lupus nephritis study called LUNAR with Rituxan. And they divided the patients in those who completely B cell depleted and those who had an incomplete B cell depletion at 1 year. And they looked at the kidney responses, and they found that the response rate was about 3.5 times higher if one had complete B cell depletion. And again, this is in the peripheral blood. So what these studies tell us is that Rituxan is not the most potent B cell depleter, but those who had complete B cell depletion did better clinically. Next slide. So how can we get better B cell depletion? Well, through engineering, obinutuzumab was created. And obinutuzumab is, I guess you consider, the granddaughter or grandson of Rituxan. It has a brand name, it's called Gazyva, and it was approved for certain types of B cell cancers in 2013. So we said, if this is a more potent B cell depleter, and that's what we need for lupus, why not do another lupus study focusing on lupus nephritis? It's the same target, CD20, but again, it's engineered in such a way to be a more potent B cell depleting agent. Next slide. And here are some characteristics, and I'm not going to go through all the specifics, but I think it's pretty interesting how the biologists, the engineers, can just transform one antibody to be a more potent B cell depleter. And so after they did that, they tested it in blood of patients with lupus. So in the test tube, but representing lupus patients' blood. And they found that it was a more potent B cell depleting antibody than Rituxan. And then it really came down to clinical trials, not in lupus just yet, but in B cell malignancies. And they found that this particular antibody, obinutuzumab, was more potent than rituximab in these B cell malignancies. Next slide. So the question was posed to me probably around 7 or 8 years ago, as I recall. Should we do another study in lupus nephritis with this more potent agent? And I said, sure, let's do it. So we did a study, it's called the Nobility Study. And we started that probably about 6 years ago. And the reason for doing it was we thought it was a better drug and there would be more B cell depletion, and more B cell depletion would be yielding a clinical result that was far better than what we saw with Rituxan. So right here, I'm just showing you what we call the pharmacodynamic data. Did it really deplete better than Rituxan? And on the left-hand side, you see the comparison between the new antibody, obinutuzumab, and Rituxan. And we're comparing the two studies, the new study that we did called Nobility, to the study with LUNAR. And you see the percentages are representing the percentage of patients who depleted below a certain level. And it doesn't really matter what that level is, but you can see higher numbers with obinutuzumab than with rituximab. Now, if you go to the right-hand side of the slide, it's kind of the same idea, but using a much more stringent threshold of B cell depletion. It says 0 cells, it was actually 0.4 cells, but that doesn't matter, it's just more stringent. And you can see a much greater percentage of the patients who received obinutuzumab depleted to that very rigorous level compared to Rituxan in the LUNAR trial. So this was biologic evidence that obinutuzumab was a better B cell depleting agent than Rituxan. But the burning clinical question, does that matter? Would that translate into better clinical results in a lupus trial? Next slide. And the short answer is that it did. So we did the Nobility trial, which was actually very similarly designed to the original LUNAR trial in lupus nephritis. And you see this histogram with response rates at 3 different times, at 1 year, at 1.5 years, and at 2 years. And you don't need to get bogged down with the numbers. But I mentioned in the very beginning what an effect size was. So that's the numerical difference between the treatment arm and the placebo arm. And like in LUNAR, in this particular study, patients came into the study on background Cellcept, mycophenolate, and we also gave them steroids. But half the group got the new antibody, obinutuzumab, the other half got a placebo. And you can see numerical superiority in the group that got obinutuzumab at all 3 time points, with the effect sizes being 12 percentage points, 20 percentage points, and 19 percentage points at the 3 different time points. And those numbers may seem low to you, that is the effect size, but those are good numbers for a lupus trial, they really are. So this was published a couple of years ago, and it served as the foundation for the phase 3 study. So this was a phase 2 study, and phase 3 is the pivotal study that can potentially lead to FDA approval. Next slide. So there are actually 2 studies with this particular antibody, obinutuzumab. The Regency study is the study in lupus nephritis, phase 3 study. And there's a study in regular lupus called the Allegory study. The Regency study, stay tuned. We hope to see results within the next couple of months. The Allegory study, on the other hand, is not going to read out probably for another year or so. So we are waiting for we are eagerly waiting these results. We hope that they're as positive as the phase 2 study that I showed you and could potentially transform the treatment of lupus nephritis. So this serves as a background for the remaining talks, but the quick lesson is greater B cell depletion seems to be achievable with the newer therapies, and it seems, at least from a preliminary perspective, to achieve greater clinical results. And I think that's my last slide.
Thank you so much, Dr. Furie. That was a very enlightening overview. And yes, you'll be joining us again just to share a bit more a bit later in the program. I'd also like to thank everyone for submitting your questions. We're keeping them on hand, and we will be asking them to our panelists toward the end of this evening's webinar. Now, I'd like to move on to our next speaker. I'm delighted to introduce Dr. Elena Massarotti, Associate Professor of Medicine at Harvard Medical School, Director of Lupus Trials, and Vice Chair of Clinical Affairs at Brigham and Women's Hospital. Dr. Massarotti will share insights on CAR T-cell therapy and its potential as a promising treatment for lupus. Dr. Massarotti, welcome.
Good evening, everyone. I'm happy to be with you tonight, and thank you for inviting me to speak. So I'd like to take off from what Dr. Furie talked about in terms of the B cells being involved in how lupus occurs, both in kidney-related lupus and the other manifestations of lupus. and talk about how we're treating lupus now and how we got to considering CAR T therapies for the treatment of lupus. Next slide, please. So when we think about the pathogenesis of lupus or how lupus evolves, there are several different considerations that have been made over the years. One is, why does it happen? Well, there are environmental factors that can lead to lupus. This is in the top part of the slide here in that oval. There are genetic factors. So some of you who may have lupus or family members will recognize that there may be autoimmune disease in the family. There are other risk factors, including lipid disorders. Being a woman puts one at risk for lupus. And then there are other genetic influences that lead to the development of lupus. And all of these factors come together to affect the immune system and lead to the expression of lupus. Some patients with lupus may just have skin disease, some may have joint disease, some may have a combination of all organs or many organs. And the key is to identify which treatment is best for that manifestation of lupus in that patient. Next slide, please. So what do we do as physicians when we're treating someone with lupus and managing the disease? Well, one of the first things we do up at the top is to control disease activity. So what we've learned over the years that there are two really important things to do when we're treating lupus. One is to control the inflammation or the disease activity. And second, to minimize the course of steroids that the patient is receiving. Because both of these factors, namely using steroids for extended periods of time and not controlling inflammation, is what leads to problems for lupus patients in their organs. The other things that we focus upon in treating a patient with lupus is to manage what we call comorbidities. So sometimes there are other complications or other illnesses that occur in the context of lupus, including high blood pressure or hypertension, diabetes that might result from steroid use, osteoporosis that might result from steroid use, elevated lipids that also might result from steroid use. And so the other flip side of that is preventing those complications of treatment. So giving vaccinations, for example, to help prevent infection, or giving cholesterol-lowering medications like statin to help prevent atherosclerosis that might lead to premature heart disease that we know might occur in lupus patients. So overall, when we're managing the patients, not only the medications to treat the disease, but there are these other complications or illnesses that might occur in the context of the illness that need to be managed. Next slide, please. So how do we treat lupus these days? Well, in addition to exercise and nutrition, which we should all participate in, there are categories of medications that we use to treat lupus. So the first group are anti-inflammatory agents, and those include medications like ibuprofen and naproxen. And these medications work non-specifically, in a sense, in the immune system along a certain particular, in the inflammatory system along a particular pathway. Then corticosteroids or steroids, like medicines like prednisone and Medrol, are also used to treat lupus. And steroids will suppress the immune system as well, turn down this very active immune system, so those B cells don't produce as many antibodies. The other group of drugs that are used commonly, very commonly in patients with lupus are antimalarials, medications like you may know as Plaquenil or chloroquine, and these work on a particular pathway in lupus. And then a large group of medications involve immunosuppressive agents that non-specifically affect the immune system. So they're not targeted to a particular molecule, but they non-specifically suppress the immune system so that there's less activity of the immune system to produce antibodies. And those medications include methotrexate, azathioprine, and mycophenolate. And then beginning, as Dr. Furie mentioned, in 2011, we began to have FDA-approved medications called biological therapies for the treatment of lupus. Belimumab was approved in March of 2011, and that attacked the B cell activating factor that Dr. Furie mentioned. And then a few years ago, another drug called anifrolumab was approved. And rituximab, though it was first approved for lymphoma, for malignancies, has also been used to treat manifestations of lupus. And then these are other categories of drugs that we use to treat lupus, calcineurin inhibitors and gamma globulin. So all of these medications work in different ways to manage the inflammation that we see in lupus. And the medications I'd like for us to focus on are the immunosuppressive agents, the biological therapies, and steroids, all of which affect the immune system. Next slide, please. So one of the best ways that we can determine whether a drug or a treatment is effective for a patient for any illness is to do a clinical trial. And when we do lupus clinical trials, one trial may be very different from another in terms of a number of different factors. But there are three aspects of a trial that I generally focus on when I compare trials, and that might be helpful for you to keep in mind as you read about trials. So one question to ask is, what is the population of the study group? Are these patients with just kidney disease? Are these patients with general lupus that have predominantly skin and joint disease? Or is it a group of lupus patients that has predominantly skin disease? And then what's the drug being used? So what's the combination of drugs? So we learned about the BLISS trials with belimumab in 2011 that involved MMF plus belimumab, rituximab trials, the LUNAR and EXPLORER trials that involved rituximab plus MMF and placebo. And then the third thing that we look at is, how do we measure whether the patient got better or did not get better? And that's called the disease activity tool. So what's the population of the trial, of the study group that the trial is addressing? What's the drug? And how are we going to figure out what's going on? But lupus trials, drug trials, are really important in terms of understanding whether a drug might work for a particular illness. Next slide, please. So we talked a little bit about rituximab and how it was first FDA approved to treat lymphomas. And it's used for many, many different malignancies and also many autoimmune diseases. And we learned from the treatment of malignancies with rituximab. Now, much in the same way that I explained how lupus may involve treatment with different drugs that attack different pathways, and we also have different treatments that might affect hypertension, and we also talked about nutrition and exercise. When we look back at the history of the treatment of malignancies, we also see that different things were used to treat malignancies. These items included surgery, sometimes an operation is done, radiation can be done, chemotherapy, which works along different pathways, DNA synthesis. Then there's bone marrow transplantation or stem cell transplantation. And then in the last 15 to 20 years has been an entity of drug therapy called immunotherapy, where the immune system is manipulated to actually attack the cancer cells. Next slide, please. So in malignancy, the next great breakthrough that's happened in the last several years is the use of CAR T therapies. And this evolved because of the evolution of genetic engineering in combination with what we learned about the immune system. So CAR T therapies represent therapies that involve the chimeric antigen receptor T cells. And essentially what's happening here, it's an advanced form of immunotherapy where the patient's own cells are used to treat the malignant cells. So this was a novel approach to treating malignancies. So in this particular situation, the patient is afflicted with a malignancy. And what happens is the patient's own cells are leukapheresed, which means are removed, and they're sifted out from one another. And the cells that are sifted out or siphoned off are called activated T cells. And then those T cells are taken and they're re-engineered, genetically engineered with a virus that inserts their genetic material into the genetic material of the cell. And then this genetically re-engineered cell is called a CAR T cell because the antigen that's re-engineered is called the chimeric antigen. So then the cells are expanded, they're grown, and then they're reinfused back into the patient. And then the CAR T cell, this new T cell with this new configuration that was generated by this genetic engineering, attacks the patient's cancer cells. Next slide. So these therapies were developed over the last several years and now have become standard of care for relapsed malignancies in lymphoma and now in multiple myeloma, and it's also being used in solid tumors. So this again evolved as a result of growth in our understanding of immunology and genetic engineering. Next slide, please. So Dr. Furie spoke with you about B cells in lupus, and there are many different drugs. I just want to go over this again because I think it's important in terms of how we understand CAR T cells. So when B cells grow in our body, they go through a number of different stages. So there's the pre-B cell, which it's sort of like the growth of a baby, if you will. And I know that's a very simplistic analogy, but the B cells are growing and developing and getting exposed to more antigens that result in these antibody selections on the surface. So the mature B cell, the fully developed B cell, has many surface antigens and surface receptors that can be targeted for depletion. So again, our goal in lupus is to eliminate the antibodies that result in the organ manifestations. And so we do that with steroids. Sometimes we do that with methotrexate or azathioprine, and we do that with immunotherapy for malignancies. And then in this particular case, we've used monoclonal antibodies like rituximab or antibodies directed against the B cell activating factor like belimumab. So these are examples of how the different drugs that we have available attack the B cells. So we talked about obinutuzumab or Guyveza, rituximab, and then these are examples of other B cell depleting therapies that are available to consider. Next slide, please. So things changed a bit in the last few years, and this is one of the great things about medicine, because I think we get better and better. We learn more and more as time goes on, so there's every reason to be hopeful. In August of 2021, there was a publication in the New England Journal of Medicine about this 20-year-old woman with lupus who had multiple organ involvement. She had kidney involvement, lung involvement, cardiac, joint and skin involvement. And she had a lot of the laboratory abnormalities that we see in patients with very active lupus. The double-stranded DNA was elevated, the complements were lower. And the patient had been treated with a number of different agents in all those different categories we had talked about earlier. So she received antimalarials with hydroxychloroquine. She continued on corticosteroids. She received a potent immunosuppressive agent called cyclophosphamide or Cytoxan, mycophenolate or MMF, calcineurin inhibitors, belimumab or Benlysta, and rituximab. Yet her disease remained active. And she underwent, on an experimental basis, physicians who were caring for her decided to try CAR T therapy with the target of being that CD20 cell that we had talked about, the B cell. And this patient, lo and behold, went into remission about a month and a half after treatment. Her blood tests became normal. And as far as, to the best of my knowledge, she continues to be in remission now, a couple of years out, almost 2 years out. Next slide, please. So that kind of was very, very provocative and caused us to ask a question. Should we examine CAR T therapy in clinical trials, like I showed you in that cartoon, in a more sophisticated and rigorous manner? So the patient that was presented, or that I presented in from 2021, was just selected, and the physician thought creatively about trying to treat the patient. But now we're at a point as well, is there enough there to compel us to do an actual trial, like we did with the rituximab trials or the Benlysta trials, to understand on a bigger scale whether this is a more effective therapy? So clinical trials can help answer this question, and many companies now have begun to look at whether CAR T therapy is right for uncontrolled general lupus without kidney involvement or with kidney involvement. And so the question is CAR T therapy right for you? And that's what we're trying to answer here. Next slide, please. Okay, so what does this look like? What does the CAR T therapy look like in the lupus trial? So here on the right are the patient's B cells, which contain surface CD20. And then the CAR T cell on the left, that's engineered. So the patient's, I'll show you another cartoon about this in a second, but the patient's own cells are removed, and then the T cells are re-engineered to be CAR T cells that attack the CD20 cell. So again, what's different here, instead of using a drug like rituximab or belimumab or Benlysta to attack the B cell, it's actually using the patient's own cells that are re-engineered and that attack the B cells. Next slide, please. So I should mention, why is this more appealing than just giving someone rituximab? Well, it appears that the degree of B cell depletion that Dr. Furie was speaking about seems to be much greater with CAR T therapies than it does with rituximab. And just like obinutuzumab seemed to be causing greater B cell depletion than rituximab, CAR T cells seem to cause much more B cell depletion as well. So CAR T cells now are being considered for many autoimmune diseases. So again, first, the cells are removed from the patient, certain cells, and then T cells are isolated. The T cells undergo re-engineering with this inactivated virus. And then the cell is reconfigured. And then those cells are grown. That's called expansion. That's grown in the lab. And then those cells are going to be reinfused into the patient. Now, to make room in the patient's body for this new population of cells, some chemotherapy needs to be administered before the cells are given, because you need to make room in the patient's body or in their bone marrow to make room for these new cells. And the conditioned chemotherapy will get rid of some of the cells temporarily to allow for these new T cells, CAR T cells, to come into the bone marrow, grow, and attack the B cells. Next slide, please. So far, there are in the not in clinical trials, included clinical trials, there are patients who've been treated with CAR T cells. There have been 8 German patients, 15 patients in the United States that are enrolled in clinical trials right now, and 12 Chinese patients. And there are many different companies looking at this, and the companies differ in how that molecule, how that CAR T cell is actually constructed. It's basically the same concept, but there are slight differences in the companies that produce the CAR T component of the CAR T cell. Next slide, please. So like all medications have side effects, potential side effects. And when we choose a therapy, we weigh the benefits versus the risks. Do the benefits outweigh the potential risks? So everything has potential side effects. So what have we learned so far about side effects with CAR T therapy? Well, because of the medications we use, like steroids and those chemotherapy drugs, infection can happen. We can get specific medication-related side effects from the meds themselves. The CAR T program requires that a patient be committed to do the study, to take the drug also, because it involves multiple visits, an extended stay in the hospital for a few days. The patients will need to be followed over a period of time to understand the repercussions over time. And then there are these known side effects of CAR T therapy that we've learned from our cancer colleagues, our oncology colleagues. One is called cytokine release syndrome. Another one is called immune effector cell-associated neurotoxicity syndrome, or ICANS. And then in the last couple of years, in lymphoma patients and cancer patients, there was some evidence of malignancy occurring in an extremely small percentage of patients who've been treated with CAR T cells for lymphomas before. This has not been seen in the patients treated with autoimmune disease, but it's going to be tracked. Next slide, please. So because of the excitement regarding this patient that was whose case was published in the New England Journal, the subsequent success shown in those patients I showed you in the other slide, CAR T therapies are also being explored in other diseases. And these are diseases for which cure has not been available, and steroids have been used, and antibodies or B cells involved in the pathogenesis of the disease. So these include diseases like rheumatoid arthritis, type 1 diabetes, refractory antisynthetase syndrome, which is a scleroderma type illness, pemphigus vulgaris, which is a disabling skin disease, certain forms of heart disease, myasthenia gravis, and then inflammatory muscle disease. And next slide. And I think that was my last slide. And I look forward to speaking with you a bit later. Thank you.
Thank you so much, Dr. Massarotti. I feel like I just learned so much. And thank you again to everyone who's here with us tonight. I see your questions coming in. I see a few of them, it seems, have been answered just through our presenters going through their slides. So I'm really happy to see that. I'm going to move on now to our next speaker. I'd like to welcome Dr. Anca Askanase, Professor of Medicine, founder and director of the Columbia University Lupus Center, and director of rheumatology clinical trials. Dr. Askanase will walk us through the current data from CAR T cell trials in lupus patients. Dr. Askanase, it is great to have you here. Thank you so much.
Thank you. A pleasure and an honor to talk about CAR T and hopefully answer questions and talk to people about the promise and the future of CAR T. So, what does the data show thus far? So, Dr. Massarotti already introduced some of the data from the Erlangen group, the group in Germany that was one of the first to propose using CAR T therapy, cell therapy for people with systemic lupus. Their first publication was the one case, the 20-year-old woman that we learned about. The second publication had 5 patients, and that was at the end of 2022. And then this is their follow-up publication in the New England Journal on 8 patients with autoimmune diseases, on 8 lupus patients, 3 with scleroderma, and patients with inflammatory myositis treated with CAR T. So they extended the type of patients that they were treating. Next slide, please. So the first one, the Nature Medicine paper, the second was the New England Journal, and in between they did another publication in Molecular Therapy Methods, and they had this lovely cartoon which tries to make the concept of cell therapy for lupus simple. As a colleague of mine used to say, it's hard to make lupus simple. I think it's hard to make cell therapy simple. But, you know, in a very simplistic way, people with active lupus are treated with CAR T. They start with high level of inflammatory cytokines, inflammatory proteins in the blood, high levels of anti-self antibodies, those double-stranded DNA antibody, Smith, RNP, ROLA antibodies in the blood, and with normal response to vaccines and pathogens. And after their treatment with CAR T, they end up in remission. And the data from the group in Germany suggested that remission is off treatment. So, and they have shared with us up to 5 years of follow-up on a patient that has been in long-term drug-free remission. As patients achieve remission, the level of most of the inflammation molecules goes down. Some, like the Bliss BAF that are responsible for the survival of B cells, goes up because CAR T kills a whole bunch of those antibody producing cells. The level of anti-self antibody decreases, and surprisingly and in a way reassuringly, the response to vaccine and pathogens stays the same. So this is a schematic of how the T cell receptor looks like and how this chimeric antigen receptor looks, and the various pieces of the chimeric antigen receptor. And this is how it works when it's targeting a tumor antigen, the same way when it targets the CD19 antigen on the surface of the B cells. The CD19 antigen is right before the CD20 antigen, so targeting the antibody producing cells. Next slide. So the patient journey. I think we already started to get a sense. Dr. Massarotti showed us a graphic representation of what happened. So the patients that either have had CAR T or are part of the clinical trials with CAR T, the lupus patients. We start like we always start for every patient with screening and understanding whether this is the right patient for the trial, whether there is active disease, whether they are medically stable, whether their bodies can safely go through the process of CAR T. We assemble a multidisciplinary team that includes the rheumatologist, the hematologist oncologist, sometimes a neurologist, and sometimes we have to also think about including someone to provide guidance in terms of fertility. So for the autologous, for the CAR T therapy that is made out of the patient's own cells, we need to start by getting rid of some of the medications that might make those T cells not as good quality for the manufacturing of these targeted cells that are now going to attack the B cells producing antigen. So we're taking away some of the medications, and then the patient comes in for, it's called leukapheresis, harvesting of the T cells. It's done through a big IV. Sometimes that IV needs to go in the neck. Sometimes if the patient has good veins, it can go in the vein in the elbow. The cells are removed. They are sent to the manufacturing place, the place where they make this engineered cell. In the meantime, we might need to put back some steroids, maybe some immunosuppressants, because this can take a couple of weeks. So we want to make sure that the patient continues to be stable before we bring them back in, sometimes 2 weeks, sometimes 3 weeks later to undergo lymphodepletion. So we need to remove some of the cells. I like a lot how Dr. Massarotti said, make room for these new cells in the bone marrow. So that's done with some chemotherapy. And about 48 hours later, it's the CAR T infusion. And then about 2 weeks of follow-up. Some products require follow-up in the hospital. Some others, it's okay for the patient to go home and just be very close to us so that we can monitor for cytokine release. So the cells that are dying, the B cells that are dying, release inflammatory molecules, and we need to watch out. What do we watch out for? Fever, decrease in blood pressure, trouble getting enough oxygen. So we need to make sure that these things are monitored carefully. And we also monitor for these neurological immune effector cell associated neurotoxicity syndrome. So we need to watch for fever, first of all, and then neurological symptoms. And then over the next 2 to 24 months, we just make sure that there are no side effects. Now is the time when we worry about some infectious complications, but we also watch for disease activity. And because there's a concern that CAR T therapy is possibly has unknown side effects, the FDA mandates for all these treatments that the patients are observed for 15 years. So this is a long time. Of course, not that intense. Once a year is good enough, as we move further out from the time of CAR T treatments. So I think that Dr. Furie and Dr. Massarotti already explained what is the rationale for using these CAR T, chimeric antigen receptor T cells that target CD19 cells. I think that we can move forward to the next slide. A lot of evidence suggesting that this is a good way to treat lupus. Now, how are these clinical trials organized? They're a partnership between the rheumatology and the hematology. And Sometimes the rheumatologists play a bigger role. You'll see like in the very beginning of the treatment on the left side of the slide, the hematologist is a little less, he's got this gray color, not so critical in making sure that we select the right patient, that we wash out the medication, and we bridge the patients until they're ready for leukapheresis. And then at the time of harvesting the cells, making room for the new cells and the CAR T infusion, the rheumatologist is a little less important. It is the hematologist that takes over and is the bigger piece at this time in treatment. Next, in terms of monitoring toxicity and making sure that we've had response, it's a little bit even between the rheumatology and the hematologist. And then as we move forward in the long-term observation for this patient, the rheumatologists take the lead. Next. So we already talked a little bit about what data is available and published, and this is a summary that I put together a couple of months ago, so it's a little bit out of date. A couple of extra stories have come forward. So about 39 patients with lupus have been treated and reported with CAR T. There are 15 patients in the US, but we have not seen reports of those patients' treatment and responses yet. 26 of the 39 were patients with systemic lupus, and 13 were patients with LN alone. So in terms of efficacy, the majority of the patients achieved remission by 3 months. All patients were off immunosuppressant therapy. Their antibody levels are lower, and these patients continue to be in disease-free remission. In terms of the risk of the cytokine release, the fever response to the fever, and possibly more severe response to the cells being killed by the treatment, they were pretty mild. The majority of the patients had the grade 1 with just a fever. There was one patient that had a grade 2 where their blood pressure went down. So, and in this initial 39 patients, we have not seen any of the neurological side effects. Now, the second and the third column look at data from the patients with myositis and scleroderma, which we're not going to be talking about today. So, next slide. You already had a flavor about the concept of why do we like to target CD20 and why CD19 was the better target that the CAR T proposed. CD19 is expressed on a wider range of the antibody producing cells, and as such it is proposed to be a better target in terms of efficacy against the antibody producing cells. And then there are some cells that don't express CD19. Those are the long-lived plasma cells. Some autoantibodies are produced by cells that don't have CD19 on their surface. And for those cells, it is suggested that maybe a different type of CAR T that targets two surface proteins on the B cells may be a more interesting way of treating their lupus. And there are clinical trials that are looking at CD19 directed CAR Ts, and then there are trials that are looking at CD19 and BCMA CAR Ts. And there's a good split of data between both of these types of T cells. And there's the suggestion that maybe the BCMA CAR T may be more effective for people that have high titer of ROLA antibodies and symptoms related to that. So more to follow as we learn more about these drugs and as we study how patients respond to these drugs. So we already looked at a little bit about the efficacy. There have been no reports of the CAR T not being able to catch, not being able to start being functional in the patients. All of the patients that were treated with CAR T effectively depleted their CD19 positive cells and were able, after a period of about 3 months, to recover their B cells. Autoantibodies were decreased, disease activity was decreased, and the majority of the patients are in treatment-free disease. We already looked at the risks of the cytokine release and the neurological side effects, and the data that we have thus far is reassuring. There's also the risk of infections, and we'll go over a little bit about what the risk is in a couple of slides. Next. The investigators from the German group looked at remission, low disease activity, and decrease in the SLEDAI score. So all of these measures are proposing that there is extraordinary efficacy. Next. So the cells, the engineered cell, the CAR T cells expand in the body. The B cells, the antibody producing CD19 positive cells go down, and that's very quick. As early as 3 days, there's already a significant decrease in those cells, and by day 7, those B cells are at 0. Soon thereafter, they start to recover. The beauty of this approach is that instead of producing B cells that can make antibodies, the patients are producing naive B cells, suggesting that this may have a long-lasting effect. The memory B cells are decreased in the beginning, and then they start to recover. The plasmablasts, the actual antibody-producing cells, are decreased, and then the immature B cells are decreased in the beginning, they start recovering, and then they reach sort of a more baseline place. And then looking at some other cells that are affected by the treatment, there's a decrease in lymphocytes, there's a decrease in CD8 and CD4 T cells, and there's a decrease in the NK cells. So across the spectrum of white cells, both lymphodepletion and CAR T therapy effectively lowers these cells. Next. So I hope I gave you a little flavor about how CAR T therapy works and how we are hoping that we are going to be able to make a huge impact on lupus activity and on the lives of people with lupus. And I have here one of my patients that bravely took on the potential benefits and the trepidation of the possible risks associated with CAR T therapy. And it is an absolute pleasure and honor to introduce Chris. And I'm going to let Jaron introduce Talaya.
Thank you so much, Dr. Askanase. That was a great detailed look at the data. So yes, I'm very excited now to welcome Christopher Cedeno and Talaya Reid, who are going to be sharing their personal experiences with CAR T cell therapy. Thank you both for joining us and being, so willing to share your experiences, especially, for this group of people that are here, interested to learn more about CAR T cell therapy. The aim of this segment is just to provide insight into your experiences with CAR T therapy, including challenges, benefits, and lessons learned. So Talaya, I'm going to start with you with my first question. Could you briefly share your journey leading to your lupus diagnosis and what ultimately led you to explore CAR T therapy as a treatment option?
Absolutely. So in 2018 is when my journey began. I noticed that I had a rash on the side of my nose, and it was like kind of itchy. So I ended up going to my primary care doctor, and initially I was misdiagnosed, and they gave me creams and stuff to try to get rid of the rash, but it wasn't helping. So I ended up going to my dermatologist, and when she looked at my skin, she immediately said that she thinks that I have lupus. She gave me a test to confirm that I had it, and I found out that I had discoid lupus, lupus nephritis, and also SLE. From then, I started getting on medications like Cellcept, tacrolimus. I did Plaquenil, Rituxan, and then Lista, and so on and so forth. But none of the medications helped with that. So my doctor reached out to me and asked if I would be interested in doing a CAR T therapy. And I decided I wanted to give it a try, since the common avenues that were taken to treat lupus weren't working for me. And that's what made me decide to go forward with the treatment.
Thank you so much for sharing that, Talaya. Chris, what was your thought process when considering CAR T therapy, and how did your health situation influence your decision to participate in a clinical trial?
So when my doctors mentioned it to me, CAR T therapy, to be honest, I was pretty much very open to it, especially when they broke it down and kind of said what was like what's the process and what's the possible outcome. And really, I was diagnosed with lupus back in 2007. So it's been a while, a lot of ups and downs, good moments, very bad moments with me with lupus, very inconsistent. And my doctors tried a lot of the things you were mentioning in the slide with Benlysta and a whole bunch of other medications that worked for a moment, for a time. So this CAR T therapy, when I was told, sounded more potentially permanent for me to not, go through what I've been going through for over 16 years. So definitely, I was very optimistic actually hearing that, and I thought personally it sounded pretty cool, pretty amazing that this process, clinical trial was available, and I ended up being a good candidate for it. So yeah.
Thank you so much. Talaya, can you walk us through your experience undergoing CAR T therapy? What were the most challenging and rewarding parts of the process?
So in the beginning, I had to receive the leukapheresis, and as mentioned earlier in the webinar, I had to come off of my medications for that. That was a little bit nerve-wracking, because I wasn't sure how my body was going to react to that, since I've been on my medications for 6 years. But I got through that, and then I had to wait for these cells to be engineered, and then after that process, when they were re-administered to me, I had to come off of my medication again. So one of the challenging things that I experienced was I had a flare when I came off the second time. And because of that, I had to be admitted into the hospital earlier than what was planned. And then the second challenge that I experienced was when I was in the hospital, after I received the cells, I was experiencing fevers and migraines. When the CAR T cells were coming in to try to remove the lupus in my body. But I would say that the most rewarding part of the whole thing is that ever since I came off the lupus medication the second time, I have not been on any lupus medication since then. So that was a win for me.
Oh, so happy to hear that. Chris, let's see. How did you manage the emotional and physical challenges during the CAR T therapy? And were there any specific moments that stood out for you?
I think for me, it was and it was very smooth. The process, to be honest, I'm very grateful to the medical staff around me, my doctors. When it comes to it, I can also relate, being off the medication for a while to kind of like see how, again, making room for those T cells to come in and have space. And I think it was, mentally make a big challenge because there is risk to it, right? There's unknown risk to it regarding to doing this process, this CAR T therapy, and things like that. So it's a lot of the things you know, again, I've gotten so used to dealing with a lot of stuff when it comes to lupus that again I gravitated to like the hope, that things will be smooth. And I kind of was, did the process with the doctors. And yes, it was kind of a little bit, because they kept, calling me. And so it was a lot of mental in a sense, because, I also have other thing at work, I was engaged at the time. I'm married now. But, just a lot of things of my life was also kicking in. So adding in this life-changing, experience and situation, it was very kind of like surreal, kind of like not really processing it, but then also processing it within the time and just trying to, stay calm because I know obviously with me, stress, when, lupus was active, or, if I get stressed or something like that, I can catch a lupus flare or something like that. So I was trying my best to kind of like not get too stressed out, But like I said, I was surrounded by people to remind me of calming down. So hopefully I answered the question.
Congratulations. Talaya, my next question for you is that after completing the therapy, how has your life changed? Are there specific improvements in your health or daily life that you've noticed?
Like I stated before, I haven't been on any lupus medication, and that's definitely something that I got used to doing. Taking something every day, multiple pills, that gets a lot. I would also say after the treatment, my fatigue that I had completely went away. Before, it would take like a lot out of me to go to work or go to school or like even spend time with like friends or family. I would get very burnt out, and I just wouldn't entertain the thought of doing extra because I just wanted to do the bare minimum of what I had to do. Also, I haven't had anything like rashes or joint pain or fluid retention. I also had that. So yeah, it's a new normal for me after 6 years to not have to worry about those things anymore.
Thank you so much. I'm glad to hear about that outcome for you. Chris, what would you say has been impact of CAR T therapy on your overall well-being? And have there been any unexpected outcomes?
To be honest, I can totally relate to this young woman as well because for me, it's been life changing. Let me tell you, and I'm not exaggerating. I'm not having lupus for 16 years, you kind of know the difference when, I've dealt with a lot of fatigue, a lot of, if I get sick, I'm gone for a week and a half, almost two. And to now experience, being sick like a normal person that doesn't have lupus, 2, 3 days, I have a little cold, but I'm back on. My energy level as well has exceeded. I'm a bit of a workaholic. I've always been that way, but now since it's so different with managing lupus and working hard and trying to build my future to now the CAR T side of it and me having that energy to do it and even push myself, but then I still don't break down. So that's something that I think key, and I would tell my doctors all the time, like, this feels different. I feel different. This is not what it was for me, when I took it back in December of last year. It's completely, that's the unexpected. I would think, there will be some remnants in regarding to having lupus for so long, but the change happened like this, especially when I came out the hospital, starting doing my normal things, and I'm noticing like, wow, it's a different, my body's responding totally different from a year ago, so I'm just, again, it's just a complete life-changing experience for me so far in this CAR T therapy clinical trial, so it's been amazing.
That is excellent. I have one more question for each of you. Talaya, what advice would you give to others with lupus who are considering CAR T therapy?
So some advice I would give is definitely have like a support system. I think that I wouldn't have been able to do this treatment without my family and my friends. They definitely helped me get through the rough patches of the therapy. And also another thing that I think that people should do is ask questions, and not only before, but during and after, because this is new and you want to make sure that you know what's going on with your body and how you're moving along and what they're giving you. And it's important to be knowledgeable on those things, because you're your best advocate, that you should know this information, because you want to get better and you know what feels right and what doesn't feel right. So I think those two things would be most important when trying to go through this therapy.
Thank you so much. So I guess on the flip side of that, Chris, what is some advice you wish that you had gotten prior to starting CAR T therapy?
This question was hard because, again, because of the very great support system I had, and I guess it would just be I guess answering more questions, but I'm doing that now, like post thing. I'm still asking my doctor's questions, still asking about my results, like blood results, like, hey, is everything good, But I think, that's most of the time. I said, just keep asking questions. Exactly. You're your best advocate, especially having lupus. It doesn't matter if you had it for a year or 20 years. That's something I would just tell myself: just ask questions, make sure you understand fully what you're getting yourself into. Yeah.
Thank you so much. Thank you both, Talaya and Chris. I know it takes a lot of courage to come and share your stories, and also a lot of care, just because your experiences are really, really important to this process, and especially to people who are, currently determining if CAR T therapy might be right for them, and they're in the audience right now, listening to your story. So it's really, really important and really helpful to them and to all of us here at LFA. So thank you both so much. I'm going
Thank you
to,
for having me.
absolutely. I'm going to return back. We have a couple more things that we're going to get through before we wrap everything up this evening. Again, just really, that was such a phenomenal interview. I feel like I've learned a lot about everything, from our past panelists and the patients that we just spoke with. And I'm sure the audience agrees. And for anyone who's just, been able to tune in, remember that we're going to be answering your questions in the panel discussion shortly. We're going to answer as many as we can. We may run out of some time, but we're going to, do our best to get to every question that we can. And also there are going to be answering some questions in the chat as well. So you can look out for answers to your questions there. And if you haven't already, please submit your questions using the Q&A feature. And so far, we've learned about the crucial role of B cells in lupus and the exciting potential of CAR T cell therapy. While CAR T is still experimental and being offered to patients whose disease doesn't respond to standard treatment, it holds great promise. Now I'd like to invite Dr. Furie back to the platform to discuss alternatives to CAR T cell therapy. Welcome back, Dr. Furie. Thank you so much.
All right, thanks. I see 99 plus questions
Yes.
there.
Yes, people are
We'll be
really
here till
engaged.
tomorrow. All right, so let me just summarize. So what we learned is that in lupus, and for unknown reasons, the immune system goes a little haywire. And one of the components of the immune system that goes haywire is the B cell. B cells make antibodies, they make our protective antibodies, but in lupus, they also make autoantibodies like the DNA antibodies. And we know that DNA antibodies, as well as some of these other autoantibodies, can damage the organs, especially like the kidneys. So we set out over 2 decades ago to try to kill B cells. And what we've learned over the last 20 years, that greater B cell depletion seems to yield greater clinical results. And so we've seen an evolution from Rituxan to the drug that I spoke about, obinutuzumab or Gazyva. And now the ultimate in B cell depletion seems to be CAR T. But as you heard, CAR T is very resource intensive. And so the question is, could scientists develop an easier way to achieve the same robust B cell depletion in the deep tissues? And you see on this slide something called a BiTE, a bispecific T cell engager. And there are some examples that have been actually approved in oncology and are being tested in rheumatic diseases. And I'll show you a cartoon of how they work. So they're the bites, the bikes, and the trikes, and don't get overwhelmed by the names. All right, next slide. So what is a frenemy? Well, I learned this word from my wife a couple of years ago. We have an indoor cat, and there's an outdoor cat that comes and has some kind of relationship with our indoor cat, though they never touch each other. And the outdoor cat launched herself from the grill that was outside of our garden window and actually went through the window. And so my wife referred to the cat as a frenemy. So I've used that term to describe a BiTE. So here you see the target, the B cell, over on the right-hand side of the slide with its protein CD20 sticking out. And we have a frenemy. So click it once more. And it's an antibody. So we're back to antibodies. We're not talking about cells, engineered cells. We're just talking about old-fashioned antibodies, but they're kind of novelly, if that's a word, constructed. So it's an antibody to CD20, and click it again, and click it once more. But it's also an antibody against something called CD3, and CD3 resides on T cells. Now, the conversations that you've been hearing about CAR T, that's to engineer a T cell to kill a B cell. Well, this seems to be a much simpler way. You give an antibody, just like you would rituximab or obinutuzumab. It can be given intravenously, and some of these antibodies can be given subcutaneously. Anyway, what happens is the antibody binds to the T cell, activates the T cell, but because it's also has reactivity with CD20, it moves over and the CD3 activated T cell kills the B cell. So just click it one more time. So the question is, can we achieve the same degree of B cell depletion in the deep tissues with this kind of construct? Because it is easier just to be able to give something intravenously as an outpatient, or for that matter, subcutaneously. So click again. And there are a couple of them out there, and they're getting harder and harder to pronounce. There's mosunetuzumab, which we refer to as Mosun, and that is a bispecific that activates the T cell and binds to CD20 on the B cell. And then there's blinatumomab, which is a similar construct, but it binds to CD19 on the B cell. So there are studies either taking place or about to take place with these particular bispecific T cell engager antibodies. Next slide. In fact, we'll hear maybe in several months about the Mosun study in lupus, just a very early phase 1 study, but you can see the drug is given subcutaneously. And next slide. But if you look at lupus nephritis alone, there are many other strategies. Some of these that are on the list actually do deplete B cells. Others have other mechanisms of action. And if I put up a list for SLE, it would probably be even longer. And I've been in this business for a long time, about 40 years treating lupus patients. And we didn't start studying novel therapies until the early 1990s. And at that time, there were just 2 therapies in development. And now there's probably about 40 to 50 drugs in development. So we've come a long way, and you've seen 3 drugs approved for 4 different indications. And I think it's just a matter of time before we see yet more drugs approved by the FDA. And the outcomes, no doubt, will improve for our patients with both SLE and also with lupus nephritis. And I think that's my last slide.
Thank you so much, Dr. Furie. We appreciate you taking the time to join us. And as you see on the screen, Dr. Joy Bowie, she's the Vice President of Research here at the Lupus Foundation of America. And she may be popping in a moment. I'm going to just go ahead and start asking some of the questions that are, that came up in the Q&A. We had a lot that came through, so I'm going to put some of them out there. So for all of our panelists, don't be shy. Feel free to jump in if we ask a question that you think that you would be able to answer. And Dr. Bowie will also be, maybe joining in and throwing a couple questions out there for our panelists, or maybe, just answering whatever she can. So I'm going to start with one of the first questions that came in. It says, I was diagnosed with SLE in 1997, then MGUS in 2009, now progressed to multiple myeloma. I'm about to select a new treatment protocol, and CAR T is one of the options. I'm wondering if CAR T would be beneficial in both the MM and SLE. So if anyone
I'll be happy to tackle that.
Well, thank you, Dr. Furie.
So first of all, it's an unusual combination. In my 40-year career, I've only had 2 lupus patients develop myeloma. And for those of you who don't know what myeloma is, it's a tumor of the plasma cells. And B cells will mature into plasma cells, and plasma cells make antibodies. The problem in myeloma is the plasma cells proliferate so much, they kind of take up too much space and can injure various organs. So we heard a little bit about targeting plasma cells. There's a CAR T program in lupus that targets a protein called BCMA, and BCMA is on plasma cells. So targeting BCMA is a strategy not only to treat myeloma, but also to treat lupus. So food for thought.
Thank you so much, Dr. Furie. The next question, I feel like I may have seen a couple variations, or just, questions that were kind of relating to the same thing. This question is it not scary to eliminate or reduce B cells when our bodies need it for other functions? I know just 3 doses of methotrexate left me so sick and feeling awful for weeks with respiratory issues. And I did see some other questions about, if we are eliminating the B cells, will our body need them for other functions? And also, what are some potential things that may happen if we eliminate the B cells? And again, any of our panelists can jump in.
Jaren, I'm happy to comment. My video is off, and I've been trying to turn it on, and I think someone, I don't know if it can be turned back on. I've been trying to start the video.
Oh, well, we can hear you though.
Okay. Let's see. There we go. Maybe that'll work now. There we go. There are, when patients' B cells are depleted or reduced, either with rituximab or other therapies, and some of the other therapies that we use also reduce B cells, not in the same way that rituximab does, and probably not, and Benlysta, not in the same way. But we've had experience with complications or side effects, if you will, of B cells being depleted. B cells make antibodies, and antibodies help to fight infection. So one of the things that can go down in the blood is something called the gamma globulin. And if a patient who's had those therapies, B cell depleting therapies, becomes recurrently infected, and that's not really very common, we can give them antibody back. And the reason why you probably felt sick with methotrexate is probably different from the reasons why someone might feel ill with B cell depleting therapy. But the consequences of B cell depletion over time, even with rituximab, they can stay depleted for months, and even up to a couple of years, hasn't been very significant. And we don't know yet what the B cells will look like with CAR T therapies and autoimmune disease. And that's one of the things that the studies will hopefully answer for us, what will happen over time. But thus far, what we've learned with rituximab therapy in lupus, we've not seen major consequences of B cell depletion.
Thank you so much, Dr. Massarotti. Dr. Bowie, would you like to jump in?
Yeah, sure. So I just wanted to address questions as it relates to how do I identify clinical trials. So there are a lot of ways to identify clinical trials, and I was going to cover it in my presentation, but I'll give the short version here. So clinicaltrials.gov is a tool that has been developed by the federal government for domestic and international trials. And so if you go to clinicaltrials.gov, you can type in systemic lupus erythematosus or lupus nephritis, and then type in cell to identify cell therapies, and then click search. And then that'll pull up all the cell therapy trials that are happening right now across the globe. And then if you want to select specifically for the US, I believe when I tried it today, about 20 studies populated. So you'll be able to identify the trials that way. And then you can see if there are any trials that are close to you in your geographic region. And then I saw a lot of questions about age, right? What are the age limitations around clinical trials, specifically related to CAR T cell therapy? So if you go to clinicaltrials.gov, again, that information will be outlined. Another good source would be to search the hospital website, the academic institutions website, but then also the Lupus Foundation of America has built a spotlight page, if you will, where we spotlight various clinical trials and we distill down information. So it's much easier for you to digest and understand as you're thinking about joining clinical trials. And so we're a great resource. You can email us as well, and we can distill down that information too. And then I wanted to highlight our Research Accelerated by You registry called RAY. It is a registry for patients and caregivers where, we collect self-reported information, but a big piece of this is for people who are interested in clinical trials. And what we do is we disseminate information through the registry about clinical trial opportunities that arise over time. And then we also want to make sure that patients are at the table when these clinical trials are being designed. So we partner with pharmaceutical companies to make sure that when protocols are being designed and when drugs are being considered for development, that patient voices are at the table through focus groups, listening sessions, key informant interviews, et cetera. And so if you're interested, we can definitely send you more information about the registry. We're going to put a QR code up in a moment, and you can scan that QR code and take the evaluation at the end. and tell us if you're interested in learning more about Reid or any other topic. If your question doesn't get answered tonight, you can also enter that information in the evaluation form, and we'll make sure that we follow up with you accordingly.
Thank you so much, Dr. Bowie. It looks like, there we go. Okay, there's the QR code. So if you could just please scan that and take a few minutes to complete the survey, just to let us know, how you felt about this experience. And again, if you have any questions that we didn't get a chance to answer, you can enter them there. We are going to be emailing everyone information on how to access the recording after we finish. And we're also going to share some information with you about the Car Hub, which is going to be on the LFA website, where we're going to do our best to try to address, questions that came up in the Q&A that we didn't have a chance to answer tonight, just because, due to lack of time, and also just to provide you with, any other vital information that you would need just to learn more about the CAR T therapy and clinical trials. So with that, I would just like to thank everyone for joining us tonight. If you have any further questions, also, you can reach out to me. My email is crump@lupus.org. Dr. Bowie is bowie@lupus.org. And we'll, do everything that we can just to see if we can get you the information that you need. And thank you so much for joining us tonight. Thank you to all of our panelists. Thank you to our patients who came and participated in the interviews. And Dr. Bowie, I'll let you take us out.
So I see in the chat there are a few other questions for the patients. And some of our panelists have agreed to stay on until 8 o'clock. So for those of you who haven't had your questions answered yet, we can stay on until 8 o'clock. And I do want to go ahead and allow the patients to just chime in really quickly. I see one specifically for Talaya. It says, "Hi, Talaya, really appreciate your insights. Did your ANA go back to negative after the trial? How would you describe your energy level? Completely go back to pre-lupus? Thanks again." And that's from Sylvia Lang.
Yeah, so when I take my tests now, they all come back negative. I haven't had any tests say that I have lupus. Yes.
Okay, thank you so much, Talaya. There's another question for the patients, I believe. Let me get to it. There's over 110 questions in here, so our apologies. We were just not able to answer all of these. Let's see. Talaya or Chris, have you noticed mental health improvement since completing the CAR T cell therapy?
I would say yes. I think I've seen improvements. Before, I guess I would be kind of like off to myself or kind of down in the dumps about certain things. But I think now that I don't have to avoid like the sunlight or anything, I don't feel that I have to seclude myself from what I consider to be normal activities that people do.
For me, mentally has helped so much. For my not just my personal future, but again, I'm a very deep person. Sorry. Like, I think about a lot of future and my relationships and stuff, a lot of things that are weighed down on me mentally with having lupus. After the CAR T, I feel like, in a sense, like I could dream again. Like, that's not exaggerating. And regarding to that I could do things I want to do, be more physical, bike, enjoy myself, exactly like they said, not be, hiding from the sun, sunscreen all day, even though you still have to wear sunscreen, but in general. But for me, mentally has been amazing, and people around me have seen the difference as well. In regarding to how I am. I've always been a very joyful person, even when lupus was active. So having this I would still have my down moments, but now I'm definitely, there's been a lot of mental improvement for sure.
Thank you so much. I saw two other questions related to timing. The first being around age, and what is the age range for an ideal CAR T-cell therapy trial participant? And that can go to one of the physicians on the call. And then the other question was around clarification as it relates to how long the follow-up time is. So whoever wants to take that, please jump in.
I think that the majority of trials look at patients between 17 and 75. And there's some variability in terms of, the youngest participants and the oldest. I think this is the range. Have we had a lot of patients that were older than 60 in any of the trials? I think that, I don't think that's the case. The oldest patient in the German study was 48, 50. So, does this mean that if you're 60, you shouldn't, think about CAR T? No, but, I'm just relaying what we know and where we have been thus far. And then duration of follow-up, right now, duration of follow-up is 15 years as recommended by the FDA.
Thank you so much. Another question that came through repeatedly is around the cadence at which CAR T-cell therapy will be administered. Is it a one-time treatment? Is there a requirement for multiple treatments? If anyone wants to take that question.
I think we'd probably all agree that we don't know, right? And that's why trials are important, because they help to answer these questions, although these trials won't answer that specific question, but ongoing trials that evolve from these initial ones. So we don't know. I think what we've learned from the German patients and the Chinese patients is that there does seem to be some durability, at least over a couple of years. Those are my thoughts. I don't know, Rich or Anca, what your thoughts are.
No, I agree with you.
I think we don't know is the best answer.
Okay. There was another question related to fertility. We know that we've heard tonight that chemotherapeutic treatments are used to prep a person prior to entering into a trial, right? So have there been any, studies looking at changes in fertility due to exposure to chemotherapeutic treatment as part of the CAR T-cell therapy protocol?
So the studies that looked at the impact of chemotherapy on fertility in lupus patients come from when we used a lot of cyclophosphamide to treat lupus nephritis and severe organ or life-threatening lupus. And there is some data from using chemotherapy for malignancy patients, but not for lupus patients. In terms of the dosing, it's 1 gram of cyclophosphamide. The majority of patients with lupus that have had cyclophosphamide have been exposed to a lot more. And we know how to try and preserve fertility. The hematology oncology and the fludarabine maybe increases that risk in terms of fertility a little bit. Our hematology oncology colleagues are very careful in informing and counseling patients about the risk, and even suggested the possibility of harvesting eggs or sperm as part of the prep procedures.
So there was another question as it relates to hospitalization and how long one might have to stay in the hospital if they were to enter into a CAR T-cell therapy trial.
Depends on the protocol. The longest is 2 weeks. The shortest for some of the allogeneic studies is 24 hours.
Okay. So it varies depending on the study. In terms of drug-free remission and what remission it actually means and how it's defined. Can someone speak to that? Because I know there's a lot of confusion around, how we define that. So it would be good to clarify.
That is a great question without a great answer. So we've come a long way. You know, we never even mentioned remission up until a few years ago. But now we have criteria for remission, for low disease activity. And I've suggested for some of the working groups that have formed that we come up with a definition of cure or immunologic remission or clinical remission. So I think that's needed.
Okay. There's another question around comorbidities and prior transplantation. Can you speak to how comorbidities or prior transplantation might impact one's ability to enter into a CAR T-cell therapy trial?
The current CAR T protocols exclude patients with a prior transplant or or a malignancy within 5 years. I mean, it's at the moment we don't know how these treatments work. What is the risk associated with them? And as such, these exclusions make sense right now. This may evolve, but for right now, this is what the protocols are putting forward.
Okay. Someone asked for a clarification on the inclusion-exclusion criteria for CAR T-cell therapy trials. I know, again, it varies depending on the protocol, but can someone give just a general oversight of, an ideal person who might be eligible for a CAR T-cell therapy trial?
So active lupus, active severe lupus, defined by our disease activity measures. So far, the majority of the protocols suggest that that needs to be the good old BILAG A, so severe disease that requires treatment with high doses of steroids. In an ideal, in a hypothetical scenario. That is in terms of activity. For lupus nephritis, the requirement is for active lupus nephritis. Some studies require a biopsy within 6 months. Others are more permissive and require a biopsy further out, up to 12 months or even further out. So active lupus that is refractory, that has not responded to the usual treatments. And in terms of making it more precise, I think that right now the wisdom is that it needs to be one immunosuppressant and maybe one biologic or advanced therapy. Different protocols have different requirements. Some are a little looser, some are more stringent. So,
okay. Thank you, Dr.
The way I
Askanase.
describe it is Goldilocks and the Three Bears. Okay, you can't be too sick and you can't be too healthy. You got to be right in the middle.
Absolutely. So we're at time. I want to wrap up. I'm sorry, Jared, I kind of took over. But thank you so much to everyone involved in making this an incredible webinar. For those of you who did not get your questions answered, like I said, please complete the evaluation form. I will send out the link to everyone who registered so that we can make sure you're able to complete that evaluation form and submit your questions so that we can try our best to get them answered. Thank you again, and we look forward to seeing you at our next research education webinar. Thank you so much.
Thank you, everyone.